I am Dr. Benjamin Levy. I'm a thoracic medical oncologist at Johns Hopkins School of Medicine, and maybe we can just go around the room and introduce one another.
My name is Dr. Wally Kern. I'm a radiation oncologist. I'm the Chief Medical Officer for Genesis Care, and I'm also Professor Emeritus at Emory University.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology and Vice Chair for Education at Memorial Sloan Kettering Cancer Center. And I'm also a Professor of Radiology at Weill Cornell Medical College.
Mike Lanuti. I'm a thoracic surgeon at Massachusetts General Hospital in Boston. I'm the Director of Thoracic Oncology for our Division of Thoracic Surgery. Also have an adjunct associate professor at Harvard Medical School.
I'm Ramaswamy Govindan, a medical oncologist with interest in lung cancer. I'm a professor of medicine at Washington University in St. Louis.
The 58-year-old stage 3 adenocarcinoma has a right upper lobe mass, 1 centimeter, with a 4R and 11R, who instead of chemoradiation received neoadjuvant chemotherapy followed by surgery. Certainly, this is a treatment paradigm that's beginning to emerge in many centers. The final pathology is a ypT1aN2M0 adenocarcinoma of the right lung. The question comes up, this patient got neoadjuvant chemotherapy followed by surgery, has residual N2 disease after surgery. Dr. Curran, do you offer radiation to these patients routinely?
In this case, yes. Residual N2 disease, I would offer radiation. If there had been a path-CR for his N1 or micrometastatic, maybe not, but I think this patient deserves the benefit of that aggressive approach.
Okay, harder question, Dr. Govindan. You gave the patient got neoadjuvant chemo, still has residual N2. Do you consider giving adjuvant chemo in these cases, or has the patient received what they're going to get in terms of systemic therapy?
I think there are a couple of important points. One is persistent N2 positivity after neoadjuvant therapy is a poor sign, or the sign of poor outcome, I would say. And that is very clear. It's not the tumor reduction that matters, it's the lymph node clearance that matters. And the second thing is, you could argue that while it is a brave attempt to do this and it's quite appropriate, these patients are known to benefit from concurrent chemoradiation followed by now durvalumab. So I would treat this patient de novo as a stage 3 disease and would use the benefit of concurrent chemoradiation. Chemo alone is one thing, chemotherapy radiation is another, and checkpoint blockade followed by that is another. So if somebody was fit enough to undergo surgery after appropriate healing, I would give the patient benefit of doubt and give concurrent chemoradiation followed by durvalumab.
Okay, great point. So this case, we would offer potentially radiation. Dr. Govindan would give concurrent chemo with that radiation with the consideration of durva for consolidation for up to a year.